everyone. Since 2 years, we have heard that there is a pandemic called coronavirus and COVID-19. These coronavirus have gave a highest mortality rate in our worldwide. This coronavirus made me get fear as always you have. I want to tell you that this coronavirus also caused a dyspnea in every person who got attacked with this. Patients are got dead or they have lost their life because of these diseases. This is mainly related to respiratory system. There is one more disorder which tells the same symptoms of a COVID, but it is not contagious. That means it doesn't spread so wide, so fastly. So today I'm here to tell a same disorder looks like a COVID, but exactly not. But it occurs rapidly. The disorder's name is called as ARDS. Yes, you heard it right. ARDS, Acute Respiratory Distress Syndrome. So let us go. What is it? Before going into that, I want you to know the parts of respiratory system. The respiratory system, as in the picture shows, that it starts from a nostril or otherwise we call as a nasal cavity. From there, it has a pharynx, larynx, trachea, and trachea is divided into a bronchus. There is right and left bronchus, which is further divided into bronchioles and alveoli. Alveoli is an air sac, and in the alveoli there is something called as surfactant, a semi-solid liquid which helps to lubricate alveolar membrane when it relaxes as well as contracts. Thereafterwards, we have two lungs and which is covered by something called as pleural cavity. One organ is there which makes a thoracic cavity as well as abdominal cavity into two parts, that is called as diaphragm. So hope you understood what are the parts in a respiratory system. Let us go now into a deeply about ARDS. So as the definition says, it is a sudden as well as progressive respiratory failure where the person is having dyspnea, refractory hypoxia and decreased lung compliance, pulmonary infiltrate. So to go into more into that, let us explain each words. I would like to explain this definition with a funny animated picture which I am showing in the PPT. So here the lung says that something happens to me immediately, suddenly something happened me, some injury has happened to the alveoli, the fluid is increased in the alveoli as well as lungs. Where lung is saying that I'm getting decreased oxygenated blood and I'm not able to give a blood supply which is oxygenated to other organs. Where brain says in this picture that look at me, please have something courtesy on me, be a kind towards me and give some oxygenated blood. Where other parts like intestine as well as a kidney says that provide a oxygenated blood which also will prevent hypoxia. So as this picture says that fluid filled in lungs or respiratory cavity is something called as pulmonary edema, which actually leads into a bilateral pulmonary infiltrate. Where another side, all others organs are not getting proper hypoxemic or something called as oxygenated blood. This will something cause hypoxemic conditions. So let us come once more and see this definition. It is an acute, sudden respiratory failure. This word I don't have to explain once more. But the word which I have to tell is hypoxemia, which is refractory. So what is this refractory hypoxemia means? Even though the oxygen is supplied to the lungs or to the nose, this will not reverse your oxemic stage. That means your alveoli is collapsed. Even though oxygen supply is there, hypoxemia is not corrected. Okay, another word, something called as lung compliance, means lung is having a capacity to inflate as well as to become small as we inhale and exhale. When this capacity is decreased, that is called decreased lung compliance. Another is called pulmonary infiltrate. That means a pus, a water or any fluid collections in the lung is something called as pulmonary infiltrate, which easily recognized with one chest x-ray. So, the ARDS is a sudden progressive respiratory disease where there is a person suffering with hypoxemia, dyspnea, and pulmonary infiltrate along with decreased lung compliance. Let us go into what is the etiology. So, as in the PPT says that there is something called as lung injury. Before you understand what is lung injury, I want to something to tell that is something, there is a word called permeability. You should know the meaning of permeability until you will not understand what is actually etiology. The permeability means the capacity of one object or layer helping to pass some solute or solvent through it. That capacity of the layer is called as something permeability. When these permeabilities increase, it allows more and more solute and solvent to pass through it. So here in etiology, what they say is that when there is a diffuse lung injury or the capillary injury, the permeability of these membrane will increase. So as it increases, the fluid will pass into inside the alveoli where there is something called as alveoli flooding, leaking of water in the lungs. So this is a main etiology which we says that causing ARDS. What are in details we can say about etiology is there are two more etiologies. One is direct and indirect. So direct, as its word says, it may not be only related to a blunt injury. It can be related to any disorders which is related to lung. Indirect means from any other systemic organs if the diseases are causing complication and causing ARDS. So let us see in detail what is a direct injury or the direct causes. Indirect injury, we say that there are some causes which is more common, some are very less common. Let us see what are there is a common causes. That is two things, pneumonia as well as aspiration of gastric content. So pneumonia, the word itself, you know that there is an infection into the lung parenchyma, which always collects or makes a consolidation inside the lung and leads to ARDS. Aspiration of gastric content. This can be happening in congenital cases like trachea and esophagus fistula, or environmental, in case if I take an example of a person with the NG tube insertion or person is connected with any aspiration tubes which will be misleaded or by mistakenly these gastric content will go into a lung cavities is called something called as aspirations of gastric content into the respiratory system, where alveoli will be flooding with the water as well as it will cause a ARDS. Then comes something called as less common things, less common causes. One is chest trauma. Always that doesn't think that person should get chest trauma. It is a less common thing. When there is a contusion or any blunt injury, there will be a layer called as endothelium will get injured and alveoli will have more water, fluid, blood. Other cause is something called as embolism. The word meaning by embolism is called as moving blood clot. So the moving blood clot inside the vessel and finally it will go and stuck into the pulmonary artery and there it will cause ARDS. Next, we'll see that something called as inhalation of toxic substance. So, inhalation of toxic substance doesn't mean that person has to smoke every time. It can be the example like as a farmer who is using pesticides to its field. So, that chemical inhalation also can cause ARDS. Then comes drowning. When the person is drowning, automatically the water will go from nostril to its respiratory area and cause alveolar flooding, leads to ARDS. Then we'll see something called as oxygen toxicity. So the oxygen toxicity, the word itself, there are some disease condition. If you give more oxygen, which will cause toxic. Toxic means a poison, which does the body does not need it. So the more oxygen you give, and the body does not need it, this will cause oxygen toxicity. The example is one is ARDS as well as COPD, where the lung is hyperventilated. Some other causes are some called as radiation pneumonitis. When the person is having a major illness, something called as cancer, that is a one common cause for your ARDS. Let us see what is there in direct injury. In direct injury, the common causes is sepsis. Sepsis is a one thing which happens to blood. When the blood is infected and when it is going into worse condition, there is something called as sepsis. And when this infection reaches to the lungs, it will cause ARDS. Other cause is called as massive trauma. You would have heard about this before. These massive trauma or something called as a multiple fractures always lead into embolisms. These embolism, as already I told, when it is reaching into the pulmonary artery, it will give a constrictions of pulmonary artery and causes into ARDS. There are some other causes like burns as well as head trauma, which will lead into a ARDS. In an indirect injury, less common causes are a pancreatitis or your anaphylaxis, CABG. Then we have a multiple blood transfusion, DIC, that is meant by disseminated intravascular coagulopathy, as well as a overdose of drug. The overdose of drug is examples are your cocaine, nicotine, or barbiturates. Let us see what are the risk factors which will contribute into your ARDS. One will be, as usual, the suspectable age called as your old age, as well as the chronic illness you are suffering from, or any other medical conditions or surgical conditions. Metabolic acidosis, where your pH is low as well as bicarbonate is low. These are the risk factors which always lead into ARDS. Let us come to see the pathophysiology. While seeing the pathophysiology, everyone are interested every time. How does this come? How does this will come? Or what is the way to come and how we can prevent it? So here also, to know this disease, you have to learn about pathophysiology. Pathophysiology is divided into three phases. So let us see in detail. Please give your concentration and listen. Unless you understand this pathophysiology, you will never understand what is ARDS. Even though it is a sudden, but it takes time to come, but the symptoms were sudden. So let us see this pathophysiology in detail. So as I said, it is divided into three phases. First phase is injury, otherwise exudate phase. So which occurs from the 24 hours to your 7 days. Next comes something called reparative or proliferative phase. The word reparative, that means something is repairing. There is a chance that patient can become healthy. So this takes the days from 7 to 21 days. Then comes a fibrotic phase. As I said, 21 days. So from 3 weeks to 4 weeks, whatever the injury occurs or the progresses occurs, that is something called as your fibrotic phase. In detail, we will go what is a injury, or extudate phase. So we will see a pathophysiology in a flow diagram. Here, in a predisposing conditions, or there are many predisposing condition, risk factors or etiological factor which will influence into ARDS. How? See here, predisposing condition always stimulate your inflammatory and immune response. When there is an immune response start to stimulate, it will attract the neutrophils and release some of the biochemical and cellular mediators, which mainly lead into two things. One, these cellular mediator, when they all come together and they form one emboli, and it will go and stuck into pulmonary artery, where pulmonary hypertension will occur and hypercapnia, that means your carbon dioxide level is increased. But at the same time here, damages of alveolar capillary leads into three things. One, the capillary is injured, where endothelium got injured. Otherwise, the surfactant which is already there in the lung is becoming inactivated, as well as new surfactant synthesis is not possible. It will be, there is a decreased synthesis of surfactant. Third one, something called as hyaline membrane formation. The alveoli membrane or the interstitial or endothelium which is injured, what it does? It will increase in the permeability. So already the word permeability I have told you. So the permeability, what it does? It will allow the fluid to and protein to pass through it. So your interstitial fluid will be collected, as well as this condition is something called as pulmonary edema. When there is a pulmonary edema, there is something called as VQ mismatch. Okay, what is this VQ? V is ventilation, another is perfusion. Ventilation meaning when I am telling this VQ match. So what is VQ? V means ventilation, P means perfusion. What is the meaning of it? So ventilation means the air comes and person inhale and air is reaching into his respiratory systems till alveoli. Perfusion means where actually the work is done. Your oxygen and carbohydrate will be exchanged and all other organs will get oxygenated blood when these oxygenated blood is reaching into your heart. So that is something when there is ventilation occurs but perfusion doesn't occur, that will also reduce lung compliance. Another thing where I was telling you about the surfactant, where surfactant is a semi-solid liquid which helps or which lubricate the alveoli when it is constrict and relax. Constrict and relax. So what happens when there is this surfactant is not there? Alveoli become instabilized and there is a chances of that lung parenchyma will collapse and that situation or condition is something called as atelectasis. Another side, there is something called as hyaline membrane secretions or fibrosis will occur. The fibrosis, the word meaning itself that there is a fiber or thick layer is produced, which is irreversible sometimes. These all three things lead into VQ mismatch as shown in the flowchart. These VQ mismatch leads further into refractory hypoxemia, where alveoli is completely collapsed and even though giving oxygen is not inadequate and your alveoli will not inflate. So giving oxygen supply is also something dangerous and causes oxygen toxicity. See in this picture, a beautifully animated picture in your slide where it says the same thing. When the cell injury occurs and the gas is not able to exchange, it will cause a hypoxia where the patient will need a mechanical ventilation. Unless the mechanical ventilation, oxygen is inadequate. Next comes a reparative or proliferative stage or phase. Here, all the alveoli start to exudate and pulmonary infiltrate has occurred. If, if at all, this disorder is progressing or worsening and the pulmonary starts to get fibrosis. And in case, in this fibrosis, your vascular resistance will be increased. Every vascular, that means your blood vessel, is having capacity of its own to constrict and relax according to your sympathetic as well as parasympathetic nerves or system acts. But what happens here? Here it will be increased vascular resistance will be there. Along with that, your pulmonary vasculatures, the blood supply which is near to your lungs will get destroyed. If if this reparative stage will stop, if it is not going into the worsened condition, that means there is a chance that patient will come into a normal situation in this phase. That's why it is something called as reparative. Patient is repairing himself to come back to the normal position. How? Reparative phases, in reparative phases, there will be something called production of type 2 pneumocytes, and the small sites, cells are situated or produced at the base of membrane. What this do? These cells will produce a surfactant. So already I told you what is the function of surfactant, where this surfactant is produced as well as there is a rapid recovery will occur. Then there is no need of any mechanical ventilations. Third stage we will go, it is something called as fibrosis. So the word already say that fibrosis all occurred in the lung parenchyma, and there is a disease called as emphysema. The bullae are formed in your alveoli. If this bullae are forming as well as there is some occlusions, that is something called as microcirculatory occlusions will happen. These occlusion will come into your bigger blood vessels, and there is something called as vascular occlusion. There is no proper blood supply. So these fibrotic changes will lead into a decreased lung compliance as well as pulmonary hypertension. So remember these words, something which I was recurrently telling you regarding pulmonary hypertensions. Now we'll see what is the clinical features. So doctor says that, hey, you are developed these symptoms from 3-4 days. That means we were not aware. The symptoms were not there from 3 to 4 days. Initially nothing is seen. Thereafterwards, suddenly one day, progressively, which is insanely progressive, patient is unknown, and one day suddenly the symptoms are seen. That's why it is something called as sudden and progressive. So what are the symptoms it shows? One is dyspnea, difficulty in breathing. Tachypnea, difficulty or increased rate. Okay, increased rate in the taking a breath. Okay, the breath per minute, usually 16 to 24, it goes more than 30. Hyperventilation, with patient is having hyperventilation. Something called as tachycardia. The heart rate usually should be 72. It goes and reaches 100 or 110. The health profession is auscultating. There is a minor amount of crackles. We say as a scattered crackles can be heard. That's why in the early stage, if ABG is taken, it doesn't shows about anything. Mild hypoxia with respiratory alkalosis. Alkalosis means that is also respiratory, where your bicarbonate is increased. That's why it is something called as respiratory alkalosis. As well as in the chest X-ray radiographic picture when it is taken, it also shows that scattered. That means in a likely there is a pulmonary infiltrate. But In the later manifestation, that means as the disease is in progress stage, it shows that air hunger. That means patient is breathing heavily, hyperventilated lungs, and patient is having confusion, irritability. That is something called, we say, as change in sensorium. Then there is, when the person is, that means health profession, when they're auscultating, he can clearly hear the diffuse crackle and bronchi. And crackle and bronchi is a complete abnormal sounds when there is a fluid collection in the lungs. ABG shows that refractory hypoxemia as well as your oxygen level, that means your PaO2 will be low. Then radiography, chest X-ray. It shows that extensive bilateral pulmonary infiltrate. What is the diagnostic evaluation? So everywhere a beautiful criteria is given to understand what is this disease is. So health profession, anyone can able to identify if they know this criteria. If the patient is having these criteria, this is ARDS. So what are the criteria? There are 5 types of criteria in this. So let us see what is criteria. One, it says that acute in onset. Even though slowly progressing inside, it is acute. That means suddenly occurred. Next, second one, partial oxygen and FI2. The ratio between partial oxygen and your FI2 gives a clear idea whether the person is in mild or severe or moderate hypoxemia as well as in ARDS. Next comes chest X-ray. Already I told you pulmonary infiltrate and consolidation is seen in radiological picture that confirms your ARDS. Fourth one, your pulmonary wedge pressure. Now what is this pulmonary wedge pressure? There is something called as catheter called a Schwann-Ganz catheter. Okay. Schwann-Ganz catheter, they are introducing into your superior and inferior vena cava. Through that, it will come to right atrium, right ventricular, and takes to pulmonary artery. They will check your pressure. The pulmonary artery pressure, if it comes below 18 mm of mercury, mm of Hg, that means it is a ARDS. The final thing of criteria is if the person is already having ARDS. So these 5 criteria will lead into or help us into diagnosed ARDS. Let us see what is the management, how to fight with this. So to fight this, we have to see what are the underlying causes which already caused these ARDS. So first, after identifying these causes or conditions, we will do one thing, that is something called as respiratory support. We give a support by a mechanical ventilation, where we keep all the lung protective strategies, how to be the FiO2, or how to keep what is the level of oxygen, what setting we should keep when the patient is able to breathe by its own. All these things we will set it in mechanical ventilation. Second, we will see about other all strategies. Example is neuroblocking agents. So what is this neuroblocking agent? We can simply call as it is a anesthesia, where the patient does not have a much sensory problems or sensations. If he is already using, then no need. But if he is not using, then would like to prefer and give a neuromuscular blocking agent. Example is acetylcholine. The third part is giving a prone position. Surprisingly, everywhere you heard that the person who is having a respiratory problem, give him Fowler's position, give him Fowler's position. First time you are hearing maybe the prone position. Why does we give prone position here? The thing is that whenever my alveolar are damaged or infiltrated, or there is a leaking fluid collections, and I am given a prone position with the ventilator. What does this prone position help for? This prone position will help you to decrease or increase pressure for the alveolar where the fluid is there and decrease the pressure where other organs are normal. When there is a decreased pressure in other places and increased pressure in the liquid collected parts, easy to chest expand as well as breathe. So remember, increased pressure where there is a problem. Next comes your nitric oxides. So we are using nitric oxide in especially in cardiothoracic cases. What does it do? Nitric acid, nitroglycerin. This do a vasodilations. So wherever you are reduced vascular resistance, where there is a emboli, this will help to dilate your valve. What happens when the dilating valve, the blood goes to all the organs and it supplies the blood supply to particular organ which is morely or which is needing it in a very badly. Surfactant replacement therapy. You would have heard about this, but in the adult clinical trial shows that this therapy is not working, but it obviously works with the premature babies. That means a 7-month baby which lung is not produced at a surfactant, it will help to them to come out from their dyspnea. Another something called as extracorporeal membrane oxygenation, a beautiful word. Extracorporeal means other than our body, something extra is doing a oxygenation. That means a machine is kept outside which act as a lung where it acts as the same your dialysis. So where your machine, when it takes the partial blood, okay, when it takes your partial blood and there is a carbon dioxide and oxygen, a transportation will occur. That means carbon dioxide go out and oxygen will come in, and from other side the oxygenated blood will come into patient body. This is something called as extracorporeal membrane oxygenation. Isn't it? It is beautiful. Something extra is doing a lung work, which helps as a management in ARDS. Then something called as a glucocorticoids. The glucocorticoids, corticosteroids always help to reduce your edema. So here also the same thing happens. The pulmonary inflammations will be reduced by glucocorticoids. Fluid management is a one more therapy. What happens in the fluid management? As you give drip, there will be overload. So here what happens is that you prevent overload by doing intake output chart. So here what happens, only intravenous crystalloid is given as well as inotropic drugs which helps heart to pump and do its maximum work. Adequate nutrition, obviously. If it doesn't have a proper food, you won't be having a capacity or you feel weakness. Same thing happens with the patient with ARDS. So they need 35 to 45 kilocalorie per kg to meet their caloric requirements. It can be a parenteral nutrition also. Then comes you monitor and prevent as well as handle the complications. Every system there is a complication when the person is having ARDS. So it's a difficult task to health profession how to bring back the patient to normal life. Let us see what are the complications which happens especially with your ARDS. First, there is an infection. In the causes, we have already told that there is something called as sepsis. It may be related to your hospital-acquired pneumonia or any catheter infections. So, we nowadays, obviously we follow COTI, catheter-associated urinary tract infection. Every 7 days, we need to see the tubes. Every 21 days, we need to change the bags. So, these are all helping and identifying small things which will prevent the infection in patient. Cardiac complication, especially related to dysarrhythmias. So what is dysarrhythmia? Rhythmically the heart is going and suddenly dysarrhythmia occur. That means irregular. Maybe it is already I said tachycardia. More. So why does we give more? Heart is beating more because properly the blood supply is not there and vascular is constricted. So we give vasodilation and heart will pump in a regular manner. Other complications are respiratory. Already I told that respiratory oxygen toxicity or fibrosis, embolism occurs. And what is this barotrauma? Now, already lung is inflated, lung doesn't constrict, that means your alveoli I am mentioning here. Already it is hyperinflated and you give oxygen, there is a chances of bursting. Barotrauma. Trauma is will be happening because of there is more pressure and volume inside. So that can be prevented by giving more oxygen. Only give the oxygen with your mechanical ventilators. Then hematological complications. Already I said DIC, disseminated intravascular coagulopathy. Along with that, we have anemia as well as thrombocytopenia. That means there is a reduction in your platelets. The platelets, when it is reduced or decreased, it is called as thrombocytopenia. Other problems. Now, think that we have kept a ET tube and connecting a person with the ventilator. What is the complication? There is this complication. One is a laryngeal ulceration and otherwise tracheal ulceration. So, the complications like this, again, the ulcerations can bleed and the bleeding will go into the respiratory system. So, health profession should take care when they introduce ET tube as well as yet to see that there will be no tracheal stenosis. Next, a psychological complications. Usually with any disorders, person will get irritated. Same thing here. The ARDS patients will be irritated with so many treatment regimens. What happens? The patient will have post-traumatic stress disorder, which the professional, the nurse, can be solved by a beautiful thing called as counseling. Beautiful organ called kidney have its own complication called as acute renal failure, AKI, acute kidney failure. This occurs when there is no proper blood supply and oxygen intake. Kidney thinks that, oh, I am not getting proper water, liquid fluid. That's why I will preserve my food and it will preserve sodium and water. When there is a sodium is preserved in the body, automatically patient's BP will be more and water is retained, automatically edema will be more. These features will be seen. So, we have to see that and prevent AKI. Next, gastrointestinal. Other than your food causing some problem, there is something called a stress ulceration. That means psychologically as well as patient is physiologically connected, isn't it? Psychologically and physiologically. So what happens here? The patients with the GI problems or complication, they will have stress ulcerations. And there is something called as a hypermetabolic stage. That means patient need more nutrition. It requires more nutrition. Otherwise, they will have something called as hypermetabolic stage. Now, being a RN, what you will do? You are a registered nurse and you are coming across a patient with ARDS. You understand the main two things. That is impaired gas exchange, otherwise ineffective airway clearance. These two things very well you identify. So, impaired gas exchange may be the lung injury or ineffective airway clearance because already the secretions are there. How you will handle? Other than this, what are the things you find? Already I said regarding more edema, AKI. So, fluid volume is excess in the body because your sodium and retention, water is retenting in the body. Other than that, you have imbalanced nutrition. less than body requirement because you're not or take. Other than that, you have something called as imbalanced nutrition level. That means you are taking less food. Next is risk for complications. Obviously, with catheter, with your ventilators, your endotracheal tube, there will be these all your diseases and treatment regimen will cause complications. Now see how we can handle one by one. Give a supplemental oxygen. The word itself, it is telling that supplemental oxygen means don't give again, more oxygen which is not needed. Giving oxygen through a mechanical ventilation, that is your FIO. Then giving a position. Already I told, not every time Fowler's position will work. You give a holter prone positions. Provide a mechanical support with the ventilators. But ventilator also need some supports. That is a routine care. While routine care is given, you will be understanding whether proper gas exchange is happening or not. Other thing, like performing suctioning. It can be with your ET tube. Positioning, already I told, a chest expansion will occur in a prone position. Whenever you are giving oxygen, need to keep it in mind that you always humidify the oxygen, which will prevent the dryness in your airway. Next is chest physiotherapy. There are 6 types or stages in chest physiotherapy. Whenever the person is getting chest physiotherapy, it's easy for him to expel whatever the sputum secretion inside. It's something called as regular fluid intake. I already said that fluid is overloaded. That doesn't mean that patient should not get fluid. Fluid balance is one work of a health profession or an RN, where she has to see daily weight of the patient as well as maintain intake output chart, recording it for every 24 hours. Parenteral nutrition, a very good manners or a very good treatment, we say. Parenteral treatment. That means everything through your IV, intravenous. Patient will be not able to have the food through your mouth. Will be able to have intravenous. So, give a parenteral nutrition. Then, provide diuretics. Why diuretics? Diuretics does its work is that urine output should be more. Fluid is retented, patient looks a plumpy and edema is diagnosed or understood by a physical examination. When you give a diuretics, these edema, excessive fluid will be excreted through your diuretics. Monitor all the complications of ARDS which is caused by mechanical ventilations. Provide routine care. So we say that this mechanical ventilation is having its own complication. That is we call as VAP, ventilator associated pneumonia. And it's being an RN, your work, that person should not get VAP. We get a different checklist to prevent the person from VAP. Do this daily routine as you enter into the ward when you're giving a care to the patients. Some other routines which you need to provide is a regular oral care, which will also prevent this ventilator associated pneumonia. Brushing the teeth, which is not able to be done by a patient, then RN can do it. By monitoring and doing these or observing these complications and preventing this, RN obviously will help in the treatment. Go through all the pictures which will identify you to remember the things and write for your 10 marks. Thank you.